Good morning. Before we start, may I ask everyone to please put on your earphones. Hello. Welcome and pleasant morning to everyone. Hope you enjoyed the first day of this historic meeting, the very first Global Ministerial Conference on Tuberculosis, especially the gala last night, gala dinner. I am Dr. Angelina. I'm the chairperson of the Committee on Health in the Philippines, House of Representatives. I'm also a member of the Executive Committee of the Global TB Caucus. I'm also a co-chair of Asia Pacific TB Caucus and a co-chair of Philippine TB Caucus. I am very pleased to participate in this first WHO Global Ministerial Conference and to moderate this parallel ministerial panel on a very important topic, and that is universal health coverage and on TB care and prevention. I am glad to accept this opportunity, both as an advocate of universal health coverage and an author of the landmark anti-TB law of the Philippines. At this very moment, we are confronted with an enormously important issue, and that is universal access to TB care and prevention. On its own, universal health coverage and TB elimination already pose immense challenges to the health sector. And taken together, they create a giant of a challenge which we must overcome. Such is our predicament, and as much as 2030 Sustainable Development Goal Target 3, or SDG 3, provide us two different yet interrelated targets, and that is to achieve universal health access and to eliminate tuberculosis. While ending TB epidemic largely hinges on the universal health coverage, the advancement of universal health coverage might be hampered by the epidemic of tuberculosis. Before us today are distinguished champions of health, the honorable ministers from and representatives from 8 diverse countries, representing 3 world regions, to give us on how the universal health coverage and the anti-TB efforts are woven to create a tapestry of health reforms. To start this session, let me first introduce the panelists and then explain the format of this panel discussion. We are honored to have with us Dr. Oli Ilunga Kalenga, Minister of Health, Democratic Republic of Congo, Dr. Professor Yifru, Minister of Health from Ethiopia, Dr. Bernard Haufiku, Minister of Health and Social Services from Namibia, Dr. Francis N. Kateh, Deputy Minister for Health Services and Chief Medical Officer, Liberia, Dr. Zbigniew Król, Deputy Minister of Health from Poland, Dr. Tan Vu Cheng, Secretary of State for Health from Cambodia, Dr. Wahid Mashrou, Director of International Relations, Ministry of Public Health, Afghanistan, Dr. Sofia Alexandru, Director, Institute of Physiognomology, Republic of Moldova. We are going to begin the panel discussion with me asking one question for each of the panelists. And the expectation is that you give your responses of no longer than 5 to 7 minutes. If we still have time, then we can ask you to add any other comments, or we can ask any dignitaries from the audience to give their insights on our topics. Please be reminded that we have to close the session by 11:15. For your information, simultaneous interpretation is available for this panel discussion. Channel number 1 is English, number 3 is French, and number 2 is Russian. Okay, let me begin by posing the first question to the Honorable Minister of the Democratic Republic of Congo, Dr. Oli Ilunga Kalenga. Please pardon me if I have pronounced your name incorrectly. Thank you. Clearly, the Honorable Minister will have to listen to the French translation of my question, and he will respond in French as well. Honorable Kalenga, what are the main challenges to universal access to tuberculosis prevention and care in the Democratic Republic of Congo, and what approaches and solutions are planned to improve the access to TB prevention and care in your country?
Okay. Thank you very much for the question. I'm going to, as you said, I'm going to answer in French. La principale difficulté, les principaux défis que nous avons pour l'accès universel à la prévention et aux soins liés à la tuberculose dans le pays sont de 3 ordres. Il y a un premier défi, c'est de dépister tous les cas de tuberculose. Le deuxième défi, c'est la connaissance réelle de l'épidémie de la tuberculose en RDC. Et le troisième défi, c'est justement le financement de la lutte contre la tuberculose. Alors, le premier défi, c'est justement de dépister tous les cas de tuberculose attendus annuellement à RDC. Parce qu'il faut constater qu'à ce jour, selon les données disponibles, moins de 50% des malades souffrant de TB sont notifiés de manière générale. Et en particulier, un peu moins de 10% des formes résistantes sont déclarées et prises en charge. Pour donner une ordre de grandeur, en 2016, 132 000 cas de tuberculose ont été déclarés, ce qui fait qu'on occupe le 3e rang en Afrique et le 12e au monde. Et il y a 759 cas de tuberculose résistante, dont 30 cas de TB ultra-résistants ont été notifiés. Seulement 54% des malades de TB connaissent leur statut VIH, 14% sont VIH+, et 75% ont accès aux ARV. Alors, les principales raisons qui expliquent cette situation, c'est la première, la couverture insuffisante en soins de santé de qualité dans le pays. Seuls 21% des 8000 formations sanitaires que compte le pays sont dotés de services TB, de diagnostic. Il y a encore une trop large utilisation d'outils de diagnostic peu sensibles comme le microscope et la radiologie conventionnelle, en lieu et place des nouveaux outils diagnostiques comme la biologie moléculaire. Ces dispositifs modernes de diagnostic sont seulement disponibles dans quelques formations sanitaires. Alors, un autre facteur limitant, c'est une approche d'offre de soins qui est très peu centrée sur le patient, et l'implication des communautés est encore insuffisante et doit être renforcée. Alors, le deuxième défi important, c'est la connaissance réelle de l'épidémie de la tuberculose en RDC. Toutes les données disponibles actuellement et qui sont utilisées en termes de projection sont essentiellement des estimations de l'OMS, par manque de réalisation d'une enquête nationale de prévalence de la tuberculose. Donc le fardeau réel de la maladie, son tableau épidémiologique ainsi que ses déterminants ne sont pas connus. Or, il est important d'avoir justement cette enquête nationale, de connaître le tableau épidémiologique complet pour pouvoir faire ce qu'on appelle un investment case, pour pouvoir faire le costing de toutes les activités de prévention, de détection et de lutte contre la maladie. Donc, très important d'avoir donc cette connaissance épidémiologique pour faire l'investment case. Ce qui nous amène à parler justement de la question donc, du financement de la lutte contre la TB en RDC. Alors, le financement, pour l'instant, est encore dépendant en grande majorité du financement extérieur. Le financement domestique représente moins de 5%. Alors, le budget global du pays, à ce jour, est de moins de 10 milliards pour une population estimée à 85 millions d'habitants. La part de budget consacrée à la santé demeure insuffisante, elle est de l'ordre de 7%. Plusieurs efforts, plusieurs progrès ont été accomplis en vue d'atteindre l'objectif de 15% destiné préconisé par la déclaration d'Abuja, mais ces efforts sont encore très lents. Et la part liée à la lutte contre la tuberculose reste encore très faible. Le faible revenu de la population explique également qu'ils sont incapables d'assurer la prise en charge financière des coûts de santé liés à la tuberculose. Alors, pour pouvoir justement essayer donc d'améliorer l'accessibilité de la population à des soins de qualité, il y a deux types d'approches. Il y a une approche tout à fait systémique au niveau du système de santé, où en fait il y a toute une série de réformes qui sont en cours en vue de renforcer le système de santé, en jouant sur tous les piliers du système, l'accessibilité, la qualité de la prestation, l'amélioration des ressources humaines, l'accessibilité aussi des produits pharmaceutiques et des produits diagnostiques. L'objectif de toutes ces réformes est justement d'avoir un système de santé durable et résilient qui est capable de garantir un accès universel de la population aux soins de santé de qualité. Alors, dans le cadre de la mise en œuvre de notre plan national de développement stratégique 2016-2020, le pays vient de valider un cadre d'investissement pour son financement effectif par la création notamment d'un fonds de solidarité nationale. Alors, ce fonds de solidarité nationale sera financé par une série de mécanismes innovants, tels que la levée des taxes sur le tabac, l'alcool, le carburant et les appels téléphoniques. Dans le cadre de la lutte contre la tuberculose, on doit aussi mettre en place un cadre de concertation multisectoriel pour justement concevoir une réponse holistique à la question de la tuberculose. Et il est important aussi que d'autres secteurs clés, tels que le ministère du Plan, le ministère du Budget, le ministère des Affaires sociales et le ministère du Travail et de la Prévalence sociale soient impliqués dans ce plan. Nous comptons aussi impliquer davantage le secteur privé pour obtenir ces différents résultats. Alors, de manière spécifique, dans le cadre pour la tuberculose, je crois que le premier point, c'est d'organiser une enquête de prévalence de la TB en RDC. Ce sera vraiment important pour justement pouvoir quantifier l'investment case et le coût de la lutte contre la tuberculose. On a toute une stratégie aussi proactive pour essayer d'étendre la couverture des soins de qualité abordables et accessibles en impliquant tous les prestataires, aussi bien les prestataires du secteur privé que du secteur public. Et alors aussi, ce sera aussi important d'adopter donc des outils de diagnostic rapides de qualité avérés en remplaçant de la microscopie qui est toujours conventionnelle. Enfin, je voulais juste terminer en disant que le projet d'aller vers la couverture sanitaire universelle en 2030 est une priorité du gouvernement. On a mis en place un conseil multisectoriel de la prévoyance sociale. Et donc, dans ce cadre de la couverture sanitaire universelle, les frais de prise en charge de la tuberculose seront complètement couverts pour la population. Et je vous remercie.
Thank you, Honorable Minister Dr. Kalenga, for such an enlightening response. The challenges highlighted by the Honorable Ministers are similarly shared and experienced by many countries. We acknowledge these challenges and the efforts of the government to address these problems. May we now proceed to the Honorable Minister of Health of Ethiopia, Dr. Professor Yifru. In the context of universal health coverage, what specific steps Ethiopia has embarked on to achieve universal access to TB care and prevention, and what will be the future direction and areas for investments to end the TB epidemic?
Thank you, Madam Chair. Ethiopia, with a population of about 100 million in East Africa, is one of the highly endemic TB cases that you'll find. However, Ethiopia made significant progress not only in TB incidence, prevalence, and TB-related mortality, but also in the other health sector, particularly in under 5 mortality, maternal mortality. We made a significant progress in the last decade. Specifically, related to TB incidence and TB-related mortality, the reduction was by more than half in the last decade. However, Ethiopia is still among the 30 high-burden TB cases for 2015 to 2020. And our annual TB incidence in 2016 was around 177 per 100,000 population, with TB-related mortality of 25 per 100,000 population per annum. The estimated MDR TB cases were also, according to WHO estimates, 2.7 among new patients and new TB patients, and around 14% among retreated TB patients. What makes us somehow in a better position in the last decade is because we instituted different strategies. Among others is the health extension program. Ethiopia launched health extension program in 2003, and so far more than 39,000 health extension workers are in the community, and they are also working in the smallest health unit, that is the health post. TB detection and giving care to TB patients is one of the 16 packages the health extension workers engaged in. This one has made really significant progress in Ethiopia, as evidence showed, the comparative study evidence showed. To cite, between 2006 and 2008, we conducted a study, a comparative study, an intervention group and a control group. The intervention group were districts, and the control group were also districts. So in the intervention group, the health extension workers were mandated to go for TB suspected cases detection, sputum collection, and as well provision of direct observation treatment for known TB patients. It has proven that in the intervention group, the detection capacity of the health extension workers was 122% as compared to in the control group, which was 69%. This is a significant difference, statistically significant difference. That's why we like to scale up this community-based TB care and TB detection and TB care. This is, I think, what works well in Ethiopia, among other interventions. The second one is we intended to improve the TB diagnostic access, and since 2014, we instituted the Gene Expert as the best diagnostic modality for resistant cases as well. Therefore, so far we have 165 Gene Experts distributed in different districts and in different facilities. And this is one modality that makes our TB detection in a better position. The third is still important, the public-private mix is also another important step that brings about a change in our TB detection and TB treatment. So the private sectors, as you know, in majority of in many of the countries and many centers are engaged in the curative service. And most of the time, unless it is business-oriented, they are not happy to work on voluntary service or this kind of services, because TB treatment in my country is free because Global Fund supports the program. The future direction that we'd like to scale up is, again, with a target of 2020, reducing the TB incidence rate by more than 20% from the 2015 baseline, and then reducing the TB-related mortality by 35%. With this target, we have strategic priority interventions, and then in our national strategic plan, scaling up the community-based TB care and prevention, and assuring the TB diagnostic access to many health facilities, and also the health facility-based TB care and the prevention, and again scaling up the public-private mix, and to assure the universal health access for TB. We instituted community-based health insurance, which is really scaling up in a rapid fashion. This is one important thing. And we are also interested in targeted TB detection. What I mean is, when we treat the carrier, as you know, like any infectious disease, we are breaking the chain. Therefore, the more cases detected and treated, the likelihood of transmitting to another person will be less and less. Therefore, we have to maximize our TB detection. To have a better access to patients living with and suffering with tuberculosis, some of the target areas that we identified are like prisons, holy water sites, and also traditional healers. And then in my country, many of the patients prefer to go to the holy water site, traditional healers. Therefore, you can find as many TB patients as possible in this site. And we'll be dealing with the religious leaders and the traditional healers to have a synergistic role in treating the TB patients, and for us to have better access for those who are suffering from TB. I hope we can reach to our target by 2020. Thank you, Madam Chair.
Thank you, Honorable Professor Yifru. We commend the implementation of community-based platform on the detection, prevention, and eradication of TB cases in your country. Community-based intervention in most jurisdictions has proven greater access to service, and it has empowered individuals or communities to early health-seeking behaviors. And as we all know, the aim of universal health coverage is to afford everyone access to health care at the time of their need without suffering financial hardships. And by empowering individuals and communities, we are not only addressing the issues of accessing service, but we also are resolving issues on inequality and human rights. May we now call on Honorable Minister of Health and Social Services of Namibia, Dr. Bernard Haufiku. Yes, we often hear this talk on multisectoral approach to addressing health problems, but translating this into reality is often the challenging part. Where does Namibia stand in this regard when it comes to universal health coverage to TB care and prevention?
Thank you very much. I actually set my iPad 7.5 minutes, so the battery will go off. You don't have to cut me, sir. I'll jump on that. Thank you very much. Namibia is one of those countries listed in the number of high burden TB cases on the African continent. I think we are among the 30 countries with higher load of TB. So the question is, what have we done as a country? First of all, we have the political commitment, and that's why I'm here, and we have a member of parliament here from a senior parliamentary caucus on TB is with us here. We have a national strategic framework on TB, which is actually an update of the previous one, even before the strategy from Geneva came in place, which is basically updated, reviewed, and just waiting for my signature to be implemented still before the end of this year. The strategy basically is built aligned with the NTB strategy of WHO and other framework on the continent, such as the African Union catalytic framework to end TB, HIV, and eliminate malaria. And also the African Union common position to end TB epidemic, which we were just framing now here in preparation for New York next year. We have a multisectoral approach and input led by the Ministry of Health and involving other ministries, such as the Ministry of Education, as we know that this is the education of all the people in the country, urban and rural development ministry, which has to do with housing, because as we know that TB is not just a bacterial issue or health issue, it's also a social issue. Living conditions contribute much more to the determination of infection. So we thought the urban ministry, it's an important partner. And then agricultural. Why? Because our sanitation and water provision falls under the Ministry of Agriculture in Namibia. So it's very important that we have Ministry of Agriculture as a partner in this multi-sectoral approach. And then the mining ministry, Ministry of Mines and Energy. As it has been said this morning, that much of the TB on the African continent and elsewhere falls in conglomerate settings, including mining, and in our region in Southern Africa, the mine workers bear the burden of TB and other infectious disease. So it's very important that we bring mines on board. And we are part of the so-called TB study in mine in Southern Africa, which is initiated and funded actually by Global Fund. So we're part of that. And then we also have the Ministry of Defense. Not only that, we're also building partnership with neighboring countries, such as Angola, which we share common border with. And we just see now, we have a memorandum of understanding with Angola regarding HIV, TB, and malaria on the border. Now, coming to the strategy, national framework of Namibia on TB, we're about 10 points, but I will probably just mention 3 or 4 out of those ones. And that goes with appropriate diagnosis of TB and managing all forms of TB, and address the issue of TB, HIV co-infection and comorbidity, as well as halting transmission and not or avoiding the economic burden, meaning that no one should suffer catastrophic financial consequences as a result of TB treatment or management or prevention. Interestingly, the strategy includes leprosy, which I have never heard being mentioned here. These are 2 types of mycobacteria that often behave in the same way, and leprosy is still a reality, by the way, so we include it in our national strategic framework. And of importance is also the issue of domestic finance raising, as I say, to avoid catastrophic results for those that are suffering from TB. So what have we achieved so far? Not perhaps the most milestone, but significant decline from incident from 12,000 and above to just about 9,000 by 26, if you compare to the figures of 2010. And I think this has been facilitated by the fact that we have improved our case finding a bit, perhaps not that much. We have also improved our diagnostic tools. We are using Gene Expert. So as a result of this, even notification also declined slightly, or notification rate declined from just over 500 cases to about 390 per 100,000 in 2016. Also, the estimated incidence slightly decreased from over 600 per 100,000 to just about over 400 cases. So our success rate in terms of treatment now stands at 87%, which is a small increase from 85% if we have to compare the baseline of 2000 or in 2010. Of note as well is the fact that we're committing 65% of the budget, total budget of TB management, is committed for by the government of Namibia through the Ministry of Health. And all our commodities, such as diagnostics and actual medications, are paid for 100% by the ministry or the government. We got support from Global Fund with other activities. Now, talking of human resources, we concentrate on training community health workers. We actually borrowed a concept from Ethiopia, which started the health extension. We went to Addis Ababa to learn from them about 4 years ago. And so far, we managed to train more than 2,000 community health workers. We call them community health workers, not health extension, maybe just to be a little bit different. And we're also taking over the previous number of people who used to be called TB field workers who were trained by Global Fund. As Global Fund winds off or change, we accommodate those people who become our community health workers. So briefly, what are the challenges for Namibia? As we know, it's a vast country close to 900,000 square kilometers with only 2.4 million people. You can imagine, and these people are not conglomerated in one city, they are scattered all over. And I think more than half of the population live in rural areas. So logistic and transport comes into place, but we're doing the best we can. We also have other issues, social issues, such as a bit of poverty here, unemployment, and other issues related to that. And as I have mentioned, the issue of sanitation is still a challenge to us. Not everybody is having running tap water. So these are all determinant and challenge that we're facing. Also, the issue of case finding, what is missing and has been mentioned yesterday, also apply to us, and especially in children. Also, diagnosing children with TB is still a big challenge in Namibia. And then comes the MDR cases. Other social issues are like alcohol issues, a problem in Namibia, HIV, TB co-infection, and we're still battling with the introduction of isoniazid prophylaxis for those that are HIV infected and TB eradicated. The funding gap now stands at about 32%, and we hope we will narrow it further, not only from the help from outside, but even with our own domestic resources. So our way forward is to maintain the multisectoral partnership, even cross-border partnership with countries such as Angola and other Southern African countries, and taking this program to the community, very important, and to be owned by the community. And also find a case. You know, when we talk about case finding, we actually think of those people that are infected, that are getting sick and going to die undiagnosed. We forgot the fact that they are actually the one transmitting the disease in the community. So when we talk about case finding, we're saying preventing death, but most importantly as well, preventing further transmission in the community. So we take it very, very serious. And then also we talk about the issue of stigma and human rights, because part of the reason why these people are not coming into care or not being identified is because they're actually scared of being discriminated and being stigmatized. So we take a serious issue with stigma, we protect human rights, and then we also want to take research to a federal level and even up to the point of participating in a TB vaccine initiative, which had been touted around the corridors this morning. Lastly, we have to promote transparency, accountability at all levels. So that's the thing from me.
Thank you, Honorable Minister Dr. Bernard Haufiku. Indeed, a multisectoral approach is important in addressing these issues, especially in this case, TB epidemic. Through the involvement and participation of sectors, both the public and private, we gain better understanding of the issues, and in turn, we create better solutions and policies. Let us now welcome our next panelist, Dr. Francis Francis and Kateh, Deputy Minister of Health Services and Chief Medical Officer from Liberia. Your question is, recently, Liberia faced a terrible crisis on Ebola virus disease. Can you please give a summary of the recovery and scale-up of TB care and prevention in the country following the Ebola crisis?
Thank you so much, and good morning to everyone. Let me begin to answer the question first by extending our profound thanks and appreciation to the organizers and also to the government of the Russian Federation for the warm hospitality. Even though it is cold here, but we feel the warmness. We want to say a big thank you. To answer the question, let me give you all just a background of why Liberia is in. And I'm saying it's in because we are confident that we are going to meet the SDG goal by target. We are very confident. And the reason here is the fact that Liberia is a very small country with a population of 4.5 million, 43,000 square miles. But most importantly, we have gone through a couple of crises, the Civil War, and just by the time we could recover from the Civil War and begin to live a normal life, we had this devastating and yet unprecedented Ebola virus disease in Liberia. But we were able to beat it. And because we're able to beat Ebola and contain it, we also feel that we can contain and end TB. So what have we done differently? Let me give you some little statistics. Basically, the TB incident rate in Liberia is 308 per 100,000. TB prevalence rate is 510 over 100,000. TB HIV serum prevalence is about 13% among TB patients. And so these are some of the things that we are looking at. But again, what is critical here is that we have in Liberia about 746 health facilities around the country. Of that total amount, during the time of Ebola, most of them shut down because people were afraid to use them and so forth. All of them are open now. But we have begun to roll out our TB program into the facility. Personally, we have about 450 of our facilities where now we are rolling out all of the TB services and moving gradually to other areas. We also deploy gene experts in the country, and this is helping us very, very well. Now we have, between 2015 to now, we have identified 92 multi-drug resistant TB cases, and they are all on treatment. TB case notification has increased from 5,035 in 2014 to 7,180 in 2016. And the success rate has increased from 72% in 2015 to 77%. We have improved integration of TB HIV services with all HIV cases screened for TB at 74%. So we are gradually going there, and like I said, we are in. But despite of that, there are few challenges, and these are things that we are working on. But before getting to the challenges, we have adopted the One Health platform. And this One Health platform is headed by the Vice President of the Republic of Liberia. And so what we are trying to do is that we cannot run healthcare system and leave out the zoonotic diseases, and so forth. So by bringing them together, using that particular platform, we can now use the same mechanism in order to tackle the containment of TB. In addition to that, during the time of Ebola, we built systems within the communities, because you cannot end TB if the community is not involved. The community has to be part and parcel. So they have the trust in us, and because of that trust component, definitely they will listen. And so we are using that community platform in order to implement the strategies that we have. Another thing we've done also is the Community Health Assistance Program, which of course we have learned from Ethiopia, and we call that Community Health Assistant, and we are training the community health assistants to make sure that in the various communities, they monitor how those affected with the disease are taking their medications and so forth. And those that are not responding, get them over to the nearest clinic and we'll go forth from there. So we are putting that, because to do this, you have to think outside the box, but also use the local context in order to make sure that you find the best fit that will end the disease. So we do have some problem with funding. We have a low case notification of 64%. We also have a high default rate of 14%. But using the Community Health Assistance Program, we know that we should be able to increase that, and also with the default rate, basically decrease that, moving towards zero. So, in terms of universal, which is the key, because we cannot do this without universal health coverage. Liberia is geared towards universal health coverage. It is a priority at every level, but most importantly, working with our partners. And let me take this time to call a few of the partners, that is Global Health, USAID, WHO, UNAIDS, PIH, BRAC, and other agencies, organization, civil society, faith-based organization. Together we are working with them in order to make sure that we end TB. Thank you.
Thank you, Honorable Dr. Kateh. Truly, the experience of devastating and catastrophic event really dampens on the implementation and achievement of our goals, especially our health agenda. And based on your experience, what is remarkable is on how the government, the private sectors, the local and international, and other stakeholders, among others, come together to support a common cause. And I think everyone will agree that we can truly surmount any odds through a mutual collaboration and support. Let us now welcome our next panelist, the Honorable Dr. Zbigniew Król, Deputy Minister of Health from Poland. Honorable Król, would you please tell us how Poland has managed near universal access to TB and MDR-TB care and prevention by integrating it to TB services into pulmonary care services?
Thank you, Madam Chair. Honorable ministers and ladies and gentlemen, let me first of all join the gratulation of my previous speaker to WHO and also the Russian Ministry of Health for the leadership and engagement which bring us here and telling about this important issue. And especially for this gathering this so many high-level experts and person of the governments across the world here in Moscow. The world has to develop more sustainable way, and governments have to assure the highest attainable level of health and well-being. That concerns also communicable diseases, tuberculosis, which is a real problem across the world right now. Let me start with a short information about epidemiological situation in Poland, where the incidence rate of tuberculosis is still a little higher than in EU countries. Starting with that, we need to be underlining a huge progress which we have in curing this disease in the last 50 years, especially this indication. I would like to share with you. In the 90s, back in 1957, the rate was 290.4 exact rate of incidence. That means that in the country was more than 82,000 people a yearly with these cases. So tuberculosis in those times was a pretty big city a year. Right now we've got back in 2016 almost 6.5 thousand cases of tuberculosis were registered. So the prevalence was more than 10 times less during these 50 years. TB incidence rate in all forms was 16.8 per 100,000 population, close to the 90% of all cases. That means around 6,000 people were new. 95% of total cases, that means more than 6,000 patients, had pulmonary tuberculosis, and 5% of all cases, what makes around 300 patients, had other than pulmonary tuberculosis. In 2015, tuberculosis was the case of more than 500 deaths in Poland. The mortality rate 1.4 per 100,000 population was the same in the previous year. So situation is, in our opinion, stable. The highest tuberculosis mortality rate was among people 65 years and older. That is 3.3 exactly rate. No deaths were reported among children and adolescents, which we are happy very much about this situation. And again, to compare the situation through the last 50 years, in 50s, the mortality rate was 105.8. That means more than 26,000 people a year dying with that cause of tuberculosis. As you can see, the important improvement is quite significant, especially during these years. Though we have not eradicated tuberculosis in Poland completely, it is completely justified to say that the Poland tuberculosis is covered with universal healthcare coverage. It was possible thanks to the multisectoral approach we have taken. As of the 50s, we registered all of tuberculosis cases through the National TB Register. The research is carried out by the Specialized Institute of Tuberculosis and Lung Diseases Institute. In 2008, that was implemented the Act on Prevention and Control of Infectious infectious diseases in humans. In January 2017, the epidemiological filter was created at the reception center of foreigners in one of our cities. Let me briefly elaborate all these issues. In Polish Institute of Tuberculosis and Lung Diseases is the institution responsible for whole strategy of prevention and fighting with tuberculosis in Poland. This institute conducting innovative research in the field of MDR, TB, namely on drug resistance to pyrazimide. So far, WHO has not performed data collection on its frequency and not recommended pyrazimide resistance tests. So we stand ready to share our knowledge on this regard. Every research conducted on tuberculosis uses the National TB Register, which is operated since 50s. This register is a unique database with complete information on tuberculosis from the whole of Poland, collected more than 70 years already. The Act of Prevention and Control of Infections and Infectious Diseases was adopted in 2008. It has been amended several times in order to adjust a current epidemiological situation. It applies to more than 60 infectious diseases. It sets out the framework of sanitary and epidemiological research, as well as for prevention mechanisms, including vaccinations. It also defines obligations of people who may be infected and obligation of medical personnel towards infected people. In line with this act, firstly, vaccination against tuberculosis is obligatory for every Polish citizen, as well as for foreigners staying in Poland for more than 3 months. Secondly, the cost of necessary medical examination and treatment, including hospital care and relevant medications, as well as obligatory vaccination, are covered from state budget for everyone, not only for those insured. Bearing in mind globalization and migration process all over the world, Polish authorities have decided to create the epidemiological screening facility. We call it epidemiological filter. Poland and in Poland, we have a special procedure to require two important these to make them these drugs, all prevention and also hospitalization available for all patients. In order to ensure a world free of tuberculosis, we need to enhance our efforts in addressing multi-faced dimension of tuberculosis. For example, we need to focus highly vulnerable groups. We need to adhere to WHO guidelines on latent TB infection. We do hope that the Moscow Declaration will provide the opportunity to increase public awareness on TB. We also do look forward on the United Nations General Assembly high-level meeting on tuberculosis, and we do hope that such a high attention paid to tuberculosis allows to research and to reach a sustainable world in minimize TB cases. Thank you very much.
Thank you, Dr. Król. We commend your country's effort in achieving universal access to TB and MDR-TB care and prevention. And we look further on a greater knowledge sharing on the innovative researches that you have done. May we now give the floor to Honorable Dr. Tan Vu Cheng from Cambodia. TB program in Cambodia has been heavily reliant on external financial support such as USAID and Global Fund. How do you prepare to achieve universal health coverage, especially for TB patients, when the external support for TB program is anticipated to decline in the future?
Thank you. Distinguished Chair and panelists, Excellency, ladies and gentlemen. It is my great pleasure to be here in Moscow to attend the first WHO Global Ministerial Conference on Tuberculosis. On behalf of the Ministry of Health of the Kingdom of Cambodia and myself, I would like to express our gratitude for the invitation and opportunity. I would like just to provide our brief response to the question as follows. During the last decade, impressive achievement in TB control has been seen with Cambodia achieving MDG target of 4 years before the schedule 2015. However, two major challenges remain to be addressed if the country were to reach the SDG target by 2030. The two challenges are programmatic and resource, as the country still faces high TB burden as well as resource challenges for combating tuberculosis. Currently, we are one of the 30 TB high burden countries. Cambodia has experienced stable economic growth in the past decade. 7% also GDP growth. In 2015, it achieved low middle income status last year. With rapid economic development and commitment from the government to expand quality care coverage, Cambodia has increased fiscal space for health. TB is one of the priority communicable disease, and the government is committed to TB control. The national budget for TB control has been steadily increasing in recent years. In addition, the first-line TB drug for adults are now supported by the national budget using a stepwise approach. 30% in 2017, 50% in 2018, 70% in 2019, and 100% in 2020 in collaboration with donor support. The recent adoption of the National Social Protection Policy Framework 2016-2025 outline the development also social assistance and security in the country for health. It contributes to the roadmap toward universal health coverage. The overall National Health Strategy Plan 2016-2020 provides clear strategic direction with the goal also having improved health outcome of the population and reduce financial burden toward universal health coverage. And the National Strategic Plan for TB Control 2014-2020 is in line with this wider plan and framework. Cambodia has reduced money mechanism to encourage performance in the health sector to provide quality and overall health system strengthening. The government is already paying and managing a mechanism called Health Equity Fund, a system for the poor that provide free health care to family and health facility level. At present, the coverage of the Health Equity Fund is 100% for the people in need, equal to 20% of the total population, around 3 million people. Despite this achievement toward the universal health coverage, many challenges remain. The Health Equity Fund only covers some diagnostic and treatment services at health facility levels and only for the poor. It does not cover the ongoing public health and operational function, especially for the national program like tuberculosis. For instance, TB case detection done through the passive case finding at health facility level and active case finding through outreach case detection activity is being carried out with donors' support at the moment. Therefore, there is a great need to find ways to sustain this activity with the domestic financing and technical capacity. Surveillance and contact investigation are both critical, important in TB control, and also require strong domestic public health function and coordination across the program to ensure sustainability. In reality, many presumptive TB patients or TB suspected before diagnosis cannot afford the transportation costs between their residents in the villages and diagnostic facility and in town. Example, referral hospital equipped with a chest X-ray and gene expert. Despite the free of charge X-ray and gene expert services, case detection delays still exist, and together with others barriers are related to around 35 missing TB cases in the country. The transportation cost is supported by the donor and mainly cover the poor at present, but no formal and wide support is available through the Health Equity Fund, except the transportation costs for some diagnosis confirmed inpatient. This is one of the major bottleneck of the early case detection of TB. Alternative support arrangements are urgently needed to overcome this hurdle. To further expand the scope of social protection for the TB patient, especially for the early case detection, concerted effort beyond Ministry of Health will be needed. For the Global Fund support 2018 2018-2020 under discussion at present. The Ministry of Finance will be the principal recipient. This will be a better arrangement in terms of coordination with other ministries and sectors beyond Ministry of Health, and for the move toward to universal health coverage for Cambodia in the future. In conclusion, in view of the further decline in internal financial support, for example, Global Fund, in the near future, Ministry of Health is planning to gradually fill the financial gap in coordination with the other ministry of the government and partner in a very strategic manner, so that those suffering from TB in Cambodia will have full access to diagnostic and treatment services at the earliest stage. A very thoroughly sought out and comprehensive transitional plan will be needed as a part of the overall strategic plan for TB control in Cambodia, especially during the period 2018-2030 toward reaching sustainable development goal. Thank you very much.
Thank you, Dr. Tan Vu Cheng. We appreciate your insights and strategies on how we can achieve universal health care despite the anticipated decline of external support. We'll now proceed to the next panelist, Dr. Wahid Mashrou from Afghanistan. We learned that Afghanistan has successfully engaged the private, non-profit, and for-profit sector in the delivery of health and TB services. What innovations has Afghanistan implemented to improve access to TB care in the context of universal health coverage?
Thank you very much. Warm greeting from my beautiful country, Afghanistan. Warm greeting from my beautiful country, Afghanistan. First, please allow me to appreciate the effort of the Ministry of Health of Russia and the WHO in arranging such a well-organized event, in facilitating a political and technical platform to fight against TB. And I'm sure that this opportunity should be marked as one of the great successes in this field. But in relation to your question, we have a high TB burden, TB disease burden in Afghanistan. According to global estimates, 61,000 people are suffering and 12,000 people are dying from TB annually. National TB Control Program, Ministry of Public Health is providing leadership for TB control. Health services delivery in country is provided through a partnership between the government and other partners. Primary health care services are provided under basic package of health services, and the secondary health care is provided under the essential package of hospital services. Under the leadership of National TB Control Program, Ministry of Public Health, TB control activities have observed tangible achievements with the support from many partners. Since 2002, Afghanistan implemented directly observed treatment short course strategy. Over the years, the population having access to DOTS has steadily increased, and currently there are 2,023 health facilities, that is 71% of the total health facilities providing DOTS. In 778, that's 61% laboratory performing sputum microscopy in both public and private sector. Our national strategic plan for TB control 2017 to 2021 encompasses specific strategic direction to reach universal health coverage for TB care by strengthening laboratory network, engaging all care providers, and empowering people with TB in communities through partnerships. Our innovations to reach universal health coverage in TB care has focused on 5 areas. First, integration of TB case management into the basic package of health services and essential package of health services. TB care are delivered free of charge to the population. The TB services rapidly expanded after integration into BPHS and APHS model, reaching universal coverage, and also this ensured the sustainability of TB program activities in the country. Second, the focus area has been intensive package for DOTS expansion. National TB control program in collaboration with partners implemented different mechanisms to expand DOTS. Partnership with private sector and other healthcare providers in big cities and urban areas of 14 provinces out of 34 provinces opened the opportunities to implement quality DOTS through their health facilities. In urban areas, considerable proportion of population first goes to private sector health facilities, seeking healthcare during a respiratory tract infection. Through the involvement of private sector and other healthcare providers other than public sector, National TB Control Program managed to capture this population and provide TB diagnosis and treatment without delay. The third achievement we have in this area is community-based DOTS. Community-based DOTS is one of the important strategies where DOTS is provided at community level to ensure universal access to TB services, and it is an effective and efficient approach to engage the communities in awareness, detection, and treatment of TB, and bring the TB service to the doorsteps of community. Community health workers play a leading role in these activities. This is implemented in 19 provinces out of 34 provinces in the country. Community-based DOTS covers a wide range of activities contributing to prevention, diagnosis, improvement, treatment, adherence, and care that positively influence the outcomes of TB treatment. The activities also include community mobilization to promote effective communication and participation among community members to generate demand for the TB prevention, diagnosis, treatment, and care services. The fourth achievement and strategic focus area in TB care in Afghanistan has been the conducting mobile clinics to reach the unreached. Mobile clinics are mainly conducted in the remote areas, whereas access to health facilities is very difficult due to several reasons. And with the support of other partners, most of the mobile clinics provide microscopy services and initiate treatment on site. If conducting microscopy is not possible, then the sputum sample collection or sputum slide preparation is done on site, which is followed by the confirmation of the diagnosis and treatment. This immensely facilitated the access to TB care for people living in hard-to-reach areas. The last but not the least has been the active case detection. Active case detection for TB is conducted mainly among internally displaced populations, prison inmates confined to mental health institutions, drug users, diabetes centers, and migrants by using digital X-ray. Presumptive cases are referred for bacteriological confirmation to use the nearest TB microscopy center, followed by DOTS. In remote areas, TB lamp is used for all HIV cases that are also screened for TB. In short, if I want to outline the interventions we have and innovations we have in achieving UHC in TB care, has been the integration of TB care in BPHS, APHS, intensive package for DOTS expansion, community-based DOTS, conducting mobile clinics to reach the unreached, in active case detection. Thank you. Спасибо большое, Russia.
Thank you very much, Dr. Mashrou. We have to excuse Dr. Tan. She has to answer a call of nature. The innovations and strategies implemented in Afghanistan are duly acknowledged. Thank you for sharing this to us today. Finally, we would like to welcome and recognize our last panelist, Dr. Sophia L. Shandru. I hope I mentioned your name correctly. Director of the Institute of Physiognomology, Republic of Moldova. Dr. Sophia, many TB patients and their families face complex and overwhelming social and economic problems. Could you please elaborate on some of the latest policy actions or innovative measures that the Republic of Moldova has been taking to tackle the social determinants of TB or other diseases?
Уважаемая госпожа председатель, уважаемые представители министерств, в Республике Молдова обеспечение всеобщего охвата услугами здравоохранения является главным приоритетом реформы здравоохранения, как это предусмотрено и европейской политикой ВОЗ «Здоровье и благополучие. Здоровье-2020». В апреле этого года на встрече министров здравоохранения стран Юго-Восточной Европы был разработан документ обязательств о сотрудничестве. Позже этот документ был представлен на 70-й сессии Всемирной ассамблеи здравоохранения, и среди всего прочего этот документ настоятельно призывает обеспечить всеобщий охват услугами здравоохранения для населения этого региона. Лечение и предупреждение туберкулеза – это та область, в которой успешно внедряется принцип «никого не оставить без внимания». В настоящее время в Республике Молдова идет процесс их национализации. Эта область и достижения в ней особенно важны для нашей страны, так как мы сталкиваемся с двойным бременем инфекционных заболеваний – ТБ и ВИЧ, а также в особенности туберкулез множественной лекарственной устойчивости. С точки зрения управления ведется работа по обеспечению более тесного взаимодействия и оптимизированных подходов и их внедрение путем объединения Министерства здравоохранения и Министерства труда, социальной защиты и семьи в августе 2017 года. Эта мера призвана повысить эффективность национальной программы по предупреждению и контролю туберкулеза на период 2016-2020 годах в части политики социальной защиты. Межотраслевое сотрудничество различных государственных органов, прежде всего Министерства здравоохранения и социальной защиты, Министерства образования, Министерства внутренних дел, Министерства юстиции и Министерства финансов, а также организаций гражданского общества обеспечивается Национальным координационным советом по вопросам ВИЧ и ТБ и его специализированными рабочими группами. Уважаемые коллеги, также я хочу сказать, что Республика Молдова входит в группу 11 стран, в которых реализуется региональный проект ВОЗ по борьбе с туберкулезом ТБ-РЕП. Цель проекта – обеспечить социально ориентированный уход при туберкулезе. Дорожная карта по реализации проекта была подготовлена Министерством здравоохранения, труда и социальной защиты с участием всех заинтересованных сторон из других секторов. Повсеместно внедрены мотивационные стимулы для пациентов и медицинских работников, в частности, оплата за качество работы врачам первичного звена и меры политики по привлечению и удержанию персонала как часть более масштабных усилий по управлению кадровыми ресурсами в области здравоохранения. Кроме этого, во всей стране внедрены продуктовые пакеты и возмещение транспортных расходов для пациентов, а также одноразовые денежные пособия для различных нужд. Созданы коммунитарные центры на местах, обеспечено начало лечения в амбулаторных условиях. Благодаря недавно созданному агентству по централизованным закупкам в сфере здравоохранения с использованием механизма международных закупок, а также благодаря предложенным поправкам к закону о лекарственных средствах в соответствии с положением Европейского Союза обеспечивается наличие лекарств гарантированного качества и медицинских товаров по доступной цене. Все это способствует укреплению финансовой устойчивости страны и постепенному отходу от донорского финансирования. Молдова успешно внедряет использование метода экспресс-диагностики туберкулеза с помощью теста GeneXpert во всех районах и городах страны, а также в тюрьмах. Уважаемые коллеги, все мы знаем и понимаем, что эффективный контроль туберкулеза невозможен без воздействия на социальные детерминанты. В этой области мы все понимаем, что это общая ответственность различных ведомств и заинтересованных сторон, как в самом секторе здравоохранения, так и за его пределами. Эта работа требует тесного сотрудничества, межотраслевых усилий и упорства. В конце концов, борьба с туберкулезом – это наша общая забота. И только объединением наших усилий мы сможем успешно достичь масштабных целей, поставленных стратегией ВОЗ по ликвидации туберкулеза как в Республике Молдова, так и в Европейском регионе ВОЗ в целом. Уважаемая госпожа председатель, разрешите мне, пожалуйста, воспользоваться случаем и выразить признательность за техническую и финансовую поддержку, оказываемую донорскими организациями и международными партнерами, в частности, Всемирной организацией здравоохранения и Глобальному фонду для борьбы со СПИДом, туберкулезом и малярией в успешном внедрении политики и оказании услуг по профилактике, лечению и уходу от туберкулеза, которую Республика Молдова получает на протяжении многих лет, а также поблагодарить российское правительство за очень теплый прием в прекрасном городе Москве. Спасибо большое.
Thank you, Dr. Sophia. The multi-country TB project and patient-centered care sounds remarkable, and the multisectoral collaboration in place in Moldova is also noteworthy. Because we don't have enough time to pose some more questions on some issues like political will and commitment, probably we can have this in some informal discussions or conversations. Before we end, I'd like to share with you our country's experience from the Philippines. It was only last year when the Comprehensive Tuberculosis Elimination Plan Act, or we call it Republic Act 10767, was signed and enacted into law. And it made the Philippines as one of the very few countries to have that landmark anti-TB law. As we all know, our country still remains in the top 30 high-burden countries, and tuberculosis remains number 8 in the leading cause of illness and disease in the country. This law seeks to increase the state investments for prevention, treatment, and control of TB disease. It also addresses the World Health Organization's visions of a world free of tuberculosis and expressed as zero deaths, disease, and sufferings due to TB through bolder policies and by harnessing supportive systems to end tuberculosis. Its implementing rules and regulation was just recently released by the Department of Health, and it was only during the last few months that this law has been enforced. This also coincides with the release of the latest, last 2016, National Prevalence Survey of the country, and we took notice of the key programmatic gaps in such as missing TB cases and accessibility issues of the poor and vulnerable population. So the TB prevalence survey revealed that TB burden in the Philippines remains high, and it is higher than previously estimated, where around 1 million Filipinos are expected to have tuberculosis. Since 2007, there has been no significant decline in the prevalence. It also shows that the current TB programs, modes of screening by symptoms and diagnosing by sputum microscopy is not sufficient for early diagnosis, and that there is a likelihood of underreporting of TB cases to the National TB Registry. But given the current gaps in the TB program, mandatory notification of TB cases and expansion of the benefit package is considered as crucial to the provisions of the anti-TB law. And the implementation of a more cohesive plan of action among TB stakeholders and strong